No, ma.
Oh, yeah. Okay. So can we start?
Yes, good to go.
Yeah. So, good evening, everybody. On behalf of IAGE, I'd like to welcome all of you for this fourth episode of the Scope and the Troca series. The focus for today's series is going to be on pelvic floor disorder, for which we have some eminent faculties who are very good at this particular topic. We have Dr. Pandit Palaskar sir, Dr. Manjula Anangani, and Dr. Sushila Saini as the faculty. And we have some esteemed chairpersons as well, Dr. Sami Pradhan, Dr. Sudha Tandon, and Dr. Sita Lakshmi. So as we all know, this pelvic disorder contributes to quite a lot of symptoms and also abnormal function of the pelvic floor musculature. So because this results in mainly the hypertonicity and the sometimes even hypertonicity of the muscles, and as a result, there'll be lots of problems like urological, gynecological, and even colorectal problems. To throw more light on this particular aspect of this disorder, we have lined up a few topics which would, though we cannot cover all of these in a single webinar, we have selected few important ones which would be covered. So I would like to welcome our President of IAGE, Dr. Kalyan Bhavade sir, to give away the welcome address, please. So Dr. Can I have the CV, Sahiti? Yeah.
It's okay, ma'am. No problem.
So Dr. Kalyan Vamade is the current president of IAG and also was the secretary, of course, and the chairperson of Infertility Committee AMOX 2023 to 25 and chairperson of Public Awareness Committee FOXing 2019 to 2022, executive committee members of IAG, Maharashtra Izar, AMOX, and also president of LATU 2021, and also organizing chairperson of AMOX and organizing secretary of MRC OG conference, and also LOGS and IAG conference in 2014, and organizing secretary of the first UR IAG 2017 and EndoWorld conference, and also organizing secretary of Pride. So we have a very young and talented president to head this esteemed organization, and over to Kalyan sir for his presidential address to welcome the gathering.
At the outset, I'd like to thank everybody who has joined for Scope and Trocar series. I'm really glad that we have a person, Dr. Malaraj, who is coordinating these webinars very well, and this is the fourth in series. Happy good report. Dr. Samir Pradhan, Dr. Manjula, Dr. Sudha ma'am, Dr. Manjula ma'am, and all the seniors who are present here. So, we are going to focus on each topic daily time. So this time we are going to focus on a topic which is very dear to everybody, that is pelvic floor prolapse, and we have none other than pelvic floor, Dr. Pandit Palaskar sir, Dr. Sujal, Dr. Sudha Tandon ma'am, and Dr. And I'd like to welcome everybody for this webinar, and all the best to all the speakers. Thank you, Dr. Mala, for organizing this for IAG.
Thank you. So thank you so much, sir. We now move on to the invocation. So with the Sahiti. So we seek the blessing of the Almighty for the smooth conduct of this conference. So I'd also like to welcome our coordinators, Dr. Santwan Mehta and Dr. Jnaneshwari for this webinar. Dr. Santwan is a very young and upcoming. Can I have the CV, Dr. Sahiti? So we have a very young and dynamic endoscopic surgeon who's really coming up in a very big way, and he is also contributing quite a lot for the Eagle projects of Foxy and IAGE. He is a young and dynamic laparoscopic surgeon from Ahmedabad, and also he has been honored with a Young Skill and Excellence Star Award in AAGL 18 conference, and also the Surgical Youth Icon Award, and has many articles in various journals, and also a certified member of the IOTA group. So we also have Dr. Jnaneshwari. He's again a young and dynamic endoscopic laparoscopic surgeon from Bangalore, and she's also contributed quite a lot to all the textbooks, and also has been a faculty in various conferences. And she's currently the secretary of the Karnataka chapter of IAGA. So our young coordinators, Dr. Santwan and Jnaneshwari, will be introducing our chairpersons. And the chairpersons will request the chairpersons to introduce the speakers. Yes, over to Dr. Santwan, please.
Thank you very much, madam. Thank you very much. I would like to thank Dr. Mala, madam, Dr. Kalyan, sir, Dr. Sujal Bhai, and Dr. Pandit Palatkar, sir, for giving me this opportunity. It's going to be a very interesting webinar for all of us. So I would like to ask my co-coordinator, Dr. Gyaneshwari, to introduce the chairperson for the first session.
Thank you, Dr. Santwan. It looks like a very promising session today. It is a great honor to introduce our chairperson for the first session. Can I have Sameer sir CV, please? Dr. Sameer R. Pradhan is currently chairing the first session today. He is done his MBBS from Seth GS Medical College. He is the director of Summer Maternity and Nursing Home, Mulund, consultant at Godrej Memorial Hospital, Vikhroli, Sushruta Hospital, a visiting consultant at various eminent hospitals. His special interests are gynec endoscopy, vaginal surgery, and high-risk obstetrics. Over to you, sir. If you could introduce the first speaker for the day.
Thank you very much, Dr. Gyaneshwari, for this kind introduction. And thank you, Dr. Kalyan and Dr. Mala and team for giving me this opportunity and honor to introduce one of my very close friends and a guru, Dr. Pandit Palatkar, just one day after the Guru Purnima. Dr. Pandit Palatkar has been a president of Indian Association of Gynec Endoscopists in the year 2023-24. And I had the first exposure to Sir during the Endo World in 2011, where he had conducted the program at Aurangabad, now Sambhaji Nagar, where he had shown a plethora of laparoscopic Shirodkar's sling surgeries. And I asked him today, he has almost done 180 lap Shirodkar sling, and then almost 300 laparoscopic sacral colpopexies. We have seen him in all of the conferences performing excellent laparoscopic tuboplasties. He has done 428 till date. And he was the person who is with Dr. Krishna Kumar at the cadaver course, which I had attended with Dr. Mala. And he has conducted almost 8 cadaver courses and 2 CSS MIG courses, which I had attended once. Besides all this, he is an avid swimmer and maintains his fitness. His center is recognized by Foxy and IIG for training endoscopy, and he is invited as an operating faculty as a guest speaker, national and international. And I remember his oration, especially his oration at IIG, which was covering almost everything on advanced laparoscopy. Over to you, Dr. Pandit. His topic today is laparoscopic repair of prolapse, cystocele, both central as well as lateral cystocele.
Thank you so much, Sameer, for the kind words, and thank you, IIG, for giving this opportunity. I'll be talking on management of the cystocele. Is my screen is visible?
Yeah. Yes, sir.
Yeah. So, friends, when the organizers gave me this topic, I thought it is a very short topic. But once I started preparing the presentation, what I realized, the cystocele usually is not present. The patient doesn't present herself as a isolated cystocele. Usually it is a part of the uterovaginal prolapse with cystocele, uterine prolapse, and the rectocele, and it may be associated with the enterocele. So most of the surgeries which we do for the prolapse, usually they have associated cystocele, enterocele, and other parts. So friend, the discovery consists of seeing what every consists of seeing what everybody has seen and thinking what nobody has thought. This particularly applies to the management of prolapse and that to the cystocele, because everybody sees the prolapse, but we have to specifically see whether this patient is having cystocele and associated problems. So pelvic organ prolapse is caused by defects in the supports of the uterus. It may be defect in the levator ani, it may be defect in the fascia, it may be defect in the perineal body. So ultimately, all these defects, they cause the loss of supports of uterus and leading to the cystocele, uterine prolapse, and enterocele. It may be associated with multiple problems. The patient may have urinary complaint. She may have problems with the coital difficulties in the coitus, and usually they may have, if the patient is young, she may be suffering from the infertility. So depending on the age of the patient, she may have the problem according to her age group. And the best part is all these prolapse cases, they can be managed by the laparoscopy. So coming to cystocele, the most common cause what we see is the post-hysterectomy and after delivery. Usually it is associated with the other prolapse of the uterus and the intestine also. And in these patients, the thorough preoperative evaluation is necessary, because we have to do the site-specific repair, and the management depends on the age, what patient wants, whether she is interested in vaginal function, and what are the associated problems with the cystocele. Coming to causes, most commonly post-hysterectomy. Usually it is common in multiparous patient due to the trauma of the deliveries. Aging and menopause is a very important cause, because with aging, with menopause, there is a deficiency of the estrogen, which leads to the deficiency of the proteins and more chances of prolapse and cystocele. If the patient is having increase chronic intra-abdominal pressure due to constipation, chronic cough, asthma, heavy weight lifting, it causes more chance of prolapse and cystocele. Some patients, they may have connective tissue disorders leading to the prolapse, and there can be family history of genetic diseases with the defect in the supports leading to the occurrence of the prolapse. So basically, why there is a prolapse and ultimately cystocele, we have to go back to the basics. Delancey has given us the 3 levels of the supports of the uterus and pelvic floor, and depending on which support is defective, it leads to the occurrence of the cystocele, enterocele, and the uterine prolapse. So usually the cystocele is caused by the prolapse. Uterine prolapse is caused by the defect at the level 1, that is cardinal and uterosacral ligament complex, and the cystocele is usually caused by the defect at the level 2, that is the attachment of the arcus tendinous fascia pelvis. There is a disconnection from the of this facial arch, and it leads to the cystocele, particularly the lateral cystocele. And if there is facial disconnection at the sacrovaginal fascia, it leads to the occurrence of the central cystocele. So which type of prolapse the cystocele patient is having, we can ascertain, we can analyze the defect, at what level the defect is lying in this patient. So the symptoms, usually the patient will have fullness or pressure in the pelvis or vagina. She may have the ball or lump protruding from the vagina, lower back pain, problems with the bladder emptying, incomplete evacuation of the urine, and some may have the dyspareunia. Urinary symptoms, patient may have urinary frequency, urgency. Some patient may have urinary incontinence, stress urinary incontinence, and difficult winding of the urine. So in all these patients, the preoperative preparation is very important. As we see in all these gynecological diseases, whether it is endometriosis or whether it is a pelvic organ prolapse, the preoperative preparation and evaluation is very important, and we have to do the per speculum examination and see what type of and what grade of cystocele is there, what associated other pelvic floor defects are there, whether there is apical prolapse, if there is enterocele, rectocele, all these problems, they have to be quantified according to the ICD classification, POPQ classification, and we have to exactly locate the defect because it is important for the site specific repair, because in prolapse surgery all defects have to be repaired in the same setting. Otherwise, if you correct the one defect, the other defect may be aggravated. So it is very important that you do the proper perioperative evaluation. Now coming to the types of cystocele, usually cystoceles are of two types: central cystocele and lateral cystocele. Lateral cystocele is more common as compared to central cystocele. There can be apical cystocele, and in most of the cases it is combined. So initially it may be lateral, but as the severity of this cystocele increases, usually it is combined. It involves all the compartments. This is a grading given by the International Continence Society, ICS. Grade 1, which is a mild prolapse of the bladder, it drops only slightly into the vagina. Stage 2 is moderate prolapse where the bladder drops into the opening of the vagina. Stage 3 is severe prolapse where the bladder bulges out of the vaginal orifice. And stage 4 is the complete, is like procedural, the complete prolapse where the bladder protrudes out of the vaginal opening. So this is important what grade the patient is having. So accordingly, we can design the surgery. These are the various surgeries available for the prolapse. Basically, all these patients of cystocele, they will be having the uterine prolapse or walled prolapse or enterocele. So either we have to do the sacral colpopexy or pectopexy along with the repair of the cystocele. So we have these various surgeries, sacral colpopexy, pectopexy. If the patient is having SUI, then we can do birch. If there is a lateral defect, lateral cystocele, we have to do the paravaginal defect repair. So I'll restrict my talk to the cystocele repair. So cystocele repair can be done if the disease is isolated, then we have to do the cystocele repair, and it can be managed either by the mesh or by the native tissue repair. So what are the aims of the surgery? Our aims of the surgery is to relieve the symptom. It is very important that we have to select the patient properly. If the patient is having asymptomatic cystocele, we don't have to repair. So it is very important that patient is symptomatic, only then it needs to be tackled. So we have to relieve the symptoms, to restore the anatomy to the normal, to restore the functions to the normal, and to prevent the recurrence in future. See, this prolapse is usually the defect in the supports of the uterus. And if you don't support the cystocele or uterine prolapse properly, she is going to have the recurrence in future. So we have to take every step that there is no recurrence. We are aware of the management of the central cystocele. We put the mesh or we do the lateral tissue, native tissue repair. But this lateral defect is a little uncommon because we don't enter into that space. And here you can see there is a detachment of the arcus tendinous fascia pelvis from its attachment, and it leads to the lateral cystocele. So in lateral cystocele, we have to reattach this arcus tendinous fascia pelvis to its original attachment or to the Cooper's ligament when the tissue are weak. It is called as the paravaginal defect repair. Now, see, this patient is having cystocele and she is also having the uterine prolapse. So this patient we manage by doing cystocele repair along with the pectopexy for the uterine prolapse. So what we do, we start with the dissection of the bladder from the lower uterine segment or cervix, and then this pectineal space is approached by taking dissecting parallel to the round ligament, and here you can see this is the pectineal ligament anterior to the this iliac vessels. So this space is approached very easily. You have to extend this bladder dissection parallel to the round ligament and parallel to the iliac vessels, and then you can easily see the uh, this pectineal ligament. See, here we have designed this mesh. This is a macroporous mesh where the pore size is more than 75 micrometer. And the here you can see it is like a rectangle. So the lower limb, it will correct the cystocele. So the size of this mesh, the lateral arms are 2 centimeter, and this arm lower size, it will correct the cystocele, and the upper part, it will support the uterus. So upper part is for the uterine suspension, and the lower part is for the cystocele. So the size of this lower part depends on how much cystocele is there. If it is too big, we have to create the big tongues, the rectangular flaps. Here you can see the mesh is fixed to the anterovaginal wall and cervix till the bladder neck, and a series of rows of 3 to 4 sutures are placed at equidistance so that there is no crumpling of the mesh. And the lateral arm of the mesh is fixed to the this pectineal ligament. We have to take deep bites. We always take 2 bites, though single bite is enough. But prolapse has a tendency for the recurrence. So to prevent the recurrence, to prevent the detachment of the mesh from the pectineal ligament, we always put one more additional stitch, that is 2 sutures. So the length of this lateral arms is 15 centimeter, which is enough for the any size of the pelvis. Though in short stature patient, if the pelvic size is too narrow, you can trim out the mesh depending on the pelvic diameters. So you can see the deep bites are taken. The advantage of this pectopexy over the sacrocolpexy is too much. We'll discuss it later on. And once it is attached, the mesh has to be extraperitonized. And this patient, they can plan pregnancy after 6 weeks of surgery, and they can try normal delivery also. But we have to avoid the difficult labor. Patient should be advised, and on discharge card, you have to write short trial of labor. Don't give a prolonged labor, or better they undergo the elective cesarean section. And if this patient they have associated enterocele, you can do the mechal caldoplasty in the same sitting by taking circular sutures to obliterate the POD, and that correct the enterocele. So the goal of medicine is not to prolong the life, but to improve the quality of life. And I think this surgery definitely it will improve the quality of the life. The second set of patient will be the walled prolapse. The patients for the walled prolapse, they also have the associated cystocele. So here you can see we are separating the bladder from the anterior vaginal wall. And again here, depending on the severity of the cystocele, we have to dissect the extent of the bladder. If it is a severe cystocele, you have to go up to the bladder neck and prepare the anterior vaginal wall. And again, the size of the mesh will depend on the severity of the what is the extent of the cystocele. Similarly, the posterior vaginal wall, the peritoneum is separated, and here you can see here the size of the mesh is bigger because here the cystocele was large. So we have to design the flap of the mesh depending on the size of the cystocele. And as far as possible, don't open the vagina, because vagina is a contaminated organ, clean contaminated organ, and it contains various bacteria. So as far as possible, don't open the vagina. If there is too much redundant vagina is there, you can do the plication sutures, which I will show in the next video, where we'll be showing you the native tissue repair. So if there is too much redundant vagina, you can do the plication of the the anterior vaginal wall, or you can do the plication of the posterior vaginal wall if it is too much redundant vagina is there due to the long-standing prolapse. So here again, you can see the lateral arm of the mesh is attached to the pectineal ligament, and the peritoneum will be closed. At the end, the posterior segment, it attaches to the posterior vaginal wall and the levator ani muscle, and that corrects the enterocele. Again, in this patient, there was enterocele, so we took the circular sutures in the pouch of Douglas, that is the mechal cardoplasty. So these are the various papers which also support that the pectopexy is a good surgical option for patient with walled prolapse and cystocele, and it gives very good results. This is another paper from JMIC which also shows that pectopexy is a promising method for the vaginal prolapse and the cystocele repair. Now coming to the sacrocolpopexy. This is a patient with walled prolapse. It is quite old video. Nowadays, we have shifted to the pectopexy because sacrocolpopexy The other speaker is talking, so I'll not focus on that. But I think the advantage of Pectopexy is we operate in the anterior compartment of the pelvis where there is no much important structure like pelvic nerves. So whenever you dissect the posterior compartment, the pelvic nerves definitely they get compromised. There can be damage. There can be entanglement of the pelvic this inferior epigastric nerve on in the mesh, and that patient may have the increased chance of constipation or chronic pelvic pain. So nowadays we have totally shifted to the Pectopexy, barring very few cases. So in Sacrocolpexy, basically the vaginal preparation is same, only the upper attachment of the mesh is to the anterior longitudinal ligament over the sacral promontory. Here again, here we prepare the Y-shaped mesh, and the anterior part of the lower end of the mesh is attached to the anterior vaginal wall. Depending on the extent of the cystocele, here again you can see we are taking a series of 3 to 4 rows of the sutures at equidistant that will avoid the crumpling of the mesh. You can put vaginal tube or the vaginal probe inside the vagina to give a platform for the placement of the sutures. And here the posterior arm is attached to the lower vaginal, posterior vaginal wall, and then it is extraperitoneous. If there are uterosacral ligaments, good, you can reattach the uterosacral ligament to the vault, and that is an additional support, which is also called as the native tissue repair. Then the mesh is fixed to the anterovaginal, the anterior longitudinal ligament, and it is extraperitoneous. Then there are again various papers also support that sacrocolpopexy gives almost 96% symptomatic relief in patient of the vault prolapse and cystocele. Cochrane review also suggests it is a good option for the management of the cystocele and the vault prolapse. When we compare sacrocolpopexy versus pectopexy, the results are equally good, but I think pectopexy is technically little easier for the new surgeons, and also the chances of the post-operative complications are less in cases of pectopexy as compared to the sacrocolpopexy. People say that there is a change in the axis of the vagina. I think it is a myth. It doesn't cause any change because the point of attachment in pectopexy and sacrocolpopexy is at the same level, that is S2 level, and there is no change in axis in pectopexy. It is a myth. Some patient with cystocele, they will have associated stress urinary incontinence. So in those cases, we have to do the Birch-Kolpow suspension. And this patient was having the lateral cystocele, so we also did the paravaginal defect repair. So how to enter for the Birch? This is entry into the space of Regius. You have to open the peritoneum above the bladder attachment, and this is a totally avascular space. You enter into the space of Regius, and by the sweeping movements, you drop the bladder, and you can see this is the bladder neck. And here you can see there is detachment of the arcus tendinous fascia pelvis from its original attachment. You can clearly see there is detachment from the lateral pelvic wall. This arcus tendinous fascia pelvis, it is a band of fascia which attached from posteriorly to the ischial spine, and anteriorly it is attached to the pubic bone. So if there is a detachment, it leads to the descent of the interval of the vagina, leading to the cystocele, lateral cystocele. So this is the Birch we are doing. This patient was having the stress urinary incontinence also. So a velical suture is taken at bladder neck. Take deep bite through the vagina and fascia. We usually prefer 2 bites. Now the previous 2 sutures, they are for the Birch suspension, and now we are doing the paravaginal defect. So in this patient, we are attaching this arcus tendinous fascia pelvis to the Cooper's ligament, because the fascia is already attenuated, so there is nothing to reattach the arcus tendinous fascia pelvis to the lateral pelvic wall. So we are reattaching it to the Cooper's ligament. So there is no distortion of the anatomy, and it is a better structure. You can see thick bites are taken through the Cooper's ligament. So this Cooper's ligament extends posteriorly as the pectineal ligament, and the lateral vaginal wall is elevated, and it corrects the Birch. It corrects the stress urinary incontinence as well as the lateral cystocele, and then the peritoneum is closed. So this is paravaginal defect. Now coming to the native tissue repair. Nowadays, there is a lot of discussion regarding whether we should use mesh or not, because mesh will discuss some complications. So to prevent the mesh complications, we can use the native tissue for the repair. Here you can see after dissection of the bladder, the uterus is retroverted and this rectangular shape, this retractor is placed in the anterior vaginal fornix to protrude the vagina, and then we take the plicating sutures. So we started from the left side, then again this is on the right side. So this is a delayed observable suture, Vicryl. You can use other suture like PDS, any delayed observable suture can take. This is the way we can plicate the vagina, right? So this approximate the vaginal fascia. We placate this vagina horizontally in two rows. So this is first row, lower row. You can see there is due to plication sutures, we take multiple bites. And once we tie this, you can see the vagina is getting shortened. The vaginal fascia is getting shortened. That was first row. Now this is the second row, upper row. So take multiple bites and the upper bite goes through the myometrium. So the fascia is reattached to the lower uterine segment. And then we start from the other angle, take multiple bites, try to avoid the entry of the needle into the vagina. Even if goes into the vagina, nothing will happen. It will get extra epithelialized in the post-operative period. Gradually withdraw this retractor into the anterior fornix. And you can see the cystocele is getting obliterated and the fascia is getting approximated, and it gives good support. And if you want to one additional, you can put mesh on this. So this will act as a thicker barrier and it will prevent the post-operative erosion of the mesh. This is how you can do the plication and the native tissue repair. And in most of the patient, this will correct the cystocele. There can be some complication during the procedure. This is a patient with walled prolapse with cystocele. So here you can see there is a loss of plane, lot of fibrosis there because this patient was having the long-standing prolapse, and due to chronic exposure to the exterior environment, there is a fibrosis is there, and the plane may get lost. So in some cases, if you are not used to the anatomy or accidentally you can open the bladder. So in this patient, there was injury to the bladder. So what we did, we reassessed the surgical situation. We reassessed the extent of the bladder, and then we dissected the bladder and the bladder was sutured in 2 layers, and then we completed the surgery. Here you can see the like a regular method, you close the bladder in 2 layers. First layer continuous, closing the mucosa, and second layer intermittent with the detrusor approximation to give the support to the first layer. Put the catheter for 14 days and the patient will be all right. Other complication of the surgery can be erosion of the mesh. If you use the mesh, we have to take mesh specific consent. It is very important that whenever you are using mesh for prolapse surgery, cystocele or uterine prolapse or any pectopexy, sacrohysteropexy, you have to take mesh specific consent, mentioning that there is chance of 10 to 15% mesh erosion in the post-operative period. It can happen after surgery at any time. It may be after 5 years, 15 years. We did this surgery 15, 20 years back, and now the patient are coming with the erosion of the mesh. So you have to explain to the patient. And whenever there is a erosion of the mesh, usually it is managed by conservative approach. Whatever the mesh can erode into most commonly into the vagina. It can erode into the bladder also. It can erode into the rectum also. So what you have to do, you have to take this patient into the operation theater, apply LS to this eroded mesh, and only cut and trim the eroded mesh through the vagina. And you can take approximating suture over that wound, or it can heal by secondary healing, give antibiotic coverage for 7 to 10 days, and usually there is no problem. So this is a patient of a mesh erosion. Here you can see this patient was operated almost 20 years back when we started the practice, and just now few months back she came with vaginal discharge, and on post speculum examination there was mesh was coming through the vagina. So and she was having a lot of back pain. So we decided to remove the mesh. And I think mesh removal after prolapse surgery is the most difficult surgery in the gynecology. It is more difficult than the endometriosis surgery because you can see due to as this mesh is a foreign body, it invites so much fibrosis. You can see it is plaster to the bone. This was patient of sacrocolpopexy. You can see it is attached to the bone like a ligament. Like it's a bony hard, so it is very difficult to remove the mesh post-operatively. Mostly because of the fibrosis, and the fibrosis will be more if it is a long duration. So you can see there is total loss of length. So gradually keeping patients, you have to dissect. And in this patient, as the mesh was so densely around the while removal of the mesh, we entered into the bladder also. Here you can see crusts were there. There is a lot of fibrosis is there due to the long-standing exposure of this mesh into the vagina. And here you can see these are the crust and a lot of fibrosis. The tracks is formed by the mesh. So the track is excised. The bladder was sutured. The anatomy of the ureter was identified, and the vagina was closed. The beauty of this post-operative surgery is there is no recurrence of the prolapse because of the lot of fibrosis. The tissues are held in plane, and usually there is no prolapse. So don't worry that if I remove the mesh, the patient will have the recurrence. It will not recur. So due to these complications of the mesh, now the various authorities, they have issued notice that the use of the mesh has to be restricted, and the consent has to be taken, and it has to be taken very seriously. Recurrence can be there if it is not done properly, though it is rare after prolapse because of if you use the mesh, there will be a lot of fibrosis, and if it is there, you can do the repeat surgery. So how to prevent these complications? Proper preoperative counseling is very important. You have to explain the risk associated, the chance of recurrence, infection, erosion. All this has to be explained to the patient in the preoperative counseling. You have to know the surgical anatomy, know and repair the defect properly. All defects, they should be identified and repaired in the same setting. Otherwise, if you repair one compartment, the other compartment will have the aggravated prolapse. Strict asepsis is very important. I always tell whenever you are doing the pelvic, you are using the mesh, the instrument, they have to be autoclaved or ETO sterilized or plasma sterilized, because once the mesh is infected, it will cause a lot of problem. Always keep mesh above the fascia. If the fascia is dissected during preparation of the vault or the anterior vaginal wall, it will increase the more chance of the erosion. So fascia should be always preserved with the vagina and vault, and it should be always the tension-free repair has to be there. If you put too much sutures tight, the sutures, they will give way, the tissues, they will give way. So it has to be tension-free repair to prevent the recurrence of the prolapse. So to conclude, thorough preoperative evaluation is necessary for the patient with pelvic organ prolapse. Pectopexy and sacrocolpopexy with cystocele repair is preferred option for the management of these patients. Choice of surgery depends on the patient's profile and surgeon's experience, and adequate precautions should be taken to prevent the recurrence and the complication. So friends, finally, knowledge and skills can make us proud, but I think the experience and wisdom makes us more humble. The benefits of surgery should always outweigh the risk to the patient, and this has to be wisely used when you are using the mesh. So thank you so much for your patient listening. Thank you, Dr. Kalyan, Sujan, and IG for giving this opportunity. Thank you so much.
Thank you, Pandit sir. That was an excellent talk. I think most of the aspects of cystocele has been covered. Over to Samir sir for his thoughtful insights.
We have time for questions, right, Mala madam and Yaneshwari madam?
Yes, 5 minutes, sir. We are a little over time.
5 minutes, no?
Yeah.
Yes.
Okay. So excellent presentation as usual, Dr. Pandit, and you have covered all the aspects. Since it is a laparoscopic conference, I will not try to go in the debate between laparoscopy and vaginal.
Yeah.
I wanted to ask certain questions regarding that mesh which you put in the first case. How low you should go, because there is something called runaway incontinence if you go too low in the anterior compartment. So what can you just throw some light about that? UV junction or just slightly above the UV junction?
Go up to the bladder neck.
Bladder neck. Okay.
Yes.
If you go slightly low, then you might cause some incontinence.
Yeah. The angle of the urethra and the uretrovesical angle will change, and the patient may have some problem with urinary complaints will be there. So again, depends depending on the severity of the cystocele, you have to design the flap of the mesh. If it is small, design small flap. If it is large, design bigger flap.
Okay. Then in the paravaginal defect, normally it was that the paravaginal tissue has to be the fascia which is separated has to be sutured to the arcus tendinous fascia pelvis.
Yeah.
You sutured it to the
Cooper's
iliopetal ligament of Cooper, so which was much higher.
Yes.
And I think you use ethibond. So you have to keep those sutures also loose then, because other it will be under tension, right? If you tighten it.
No, the
First, we
tension
keep
has to be just adequate.
like a hammock.
The tension has to be just adequate to leave the pelvic floor.
Okay.
It should not be too loose or it should not be too tight.
No, because if it is the levels are much higher, does it? And when the CO2 insufficient is there, won't tightening cause any cut through or this? That is my.
No. You always take double bite, helical bite through the arcus tendinous fascia pelvis. And as this is a patient with prolapse, usually they are postmenopausal. There is weakening of the lateral attachment also. So there is no fascia is left to reattach the arcus tendinous fascia pelvis. So that's why I attach to the Cooper's ligament.
Okay.
Because the whole pelvis is weak.
Then you said you have to be above the facial layers. Now in our laparoscope, when we went for the cadaver training, you had taught us, and even Dr. Puntambekar's book mentions that one has to always be while dissecting between the two layers of fascia.
Yes.
So there are blood veins between the fascia and
below the fascia.
viscous. Like there can be veins between the fascia and the cervix and the fascia and the bladder. So when you are between the two layers of fascia, you get a bloodless plane, and that is what we saw in your dissections also.
Yeah.
Then another thing which mentioned there was when you are between the two layers of fascia for all surgeries for that matter, even if I do vaginal surgeries now, after doing that cadaver course, it has helped me in my vaginal dissection also. Then there is no fibrous tissue, they say. In that book also it has been mentioned, because no fibrosis occurs there because fibroblasts cannot grow. So how does in this prolapse cases, when you place the mesh between the two layers of fascia, the fibroblasts grow? It is because of the foreign body in reaction, the mesh which causes, or is there any other pathology?
There is as the mesh is a foreign body, it causes intense fibrosis.
Okay.
And that fixes the mesh to the fascia and ultimately the vagina.
Yeah, it just fixes like a Feviquick. I saw that complication which you showed. The other thing is, we have seen certain cases where even after laparoscopic repairs, it has come as a recurrence. And then I personally feel that we don't have anything else. So should a general gynecologist decide to use this laparoscopic mesh surgeries selectively for recurrent cases or as a primary repair? Like what is wrong with our old traditional teachings where we now do site-specific repairs vaginally? Because this question had asked Dr. Noe Gunther also when he had come for Pune conference, where he was plicating, as you showed the plication of the vagina. We do the same thing vaginally also, like laparoscopically plicating. And he has categorically told that time that a primary surgery should be without the mesh. And the recurrent surgeries should be with mesh, because he did all the primary repairs laparoscopically by plicating. And he was using that PVDF material, which is quite expensive. The mesh is very expensive. So what are your thoughts?
What I think is the primary surgery should be the best surgery. Why to give a chance for recurrence? See,
no, but we have seen recurrence with the mesh also, no?
This patient
we can the complications with mesh are only can be handled by very experts like you. So if a general gynecologist takes from this message that the vaginal surgeries are quite or prolapse are now outdated and we should do mesh for everything, it may land up with a mess.
No. See, Samir, if the patient is young, premenopausal, there is a lot of estrogen secretion is there, and if you see the premenopausal patient, usually the native tissues are good. So I think if the patient is young, you can use the native tissue repair, and intraoperatively you have to decide, if you want to do the uterosacral ligament fixation. In those cases, if the uterosacral is there, in that case you can use native tissue.
I always
If
thought
the tissues are thin, if the patient is postmenopausal, I think better we go for mesh.
because I thought if the patient is young, the tissues are better, the
Yeah.
chance of mesh erosion are less, and
Yes.
the mesh, the repair has to last for a longer time. That time you should use mesh. And the
Yes.
patients are old, there is a more chance of mesh erosion. That time one should not use the mesh. I had a lot of discussion with Dr. Vivek Patkar sir long time back when vaginal meshes like prolapse were used, and he told me his observations when he had done a lot of prolapse procedures, that the vagina becomes like a thick board after the mesh surgeries, and the subsequent intimacy becomes a big problem. So you
Miserable.
have such a large series, and I believe even for your histopexis, you have shifted from Shirodkar's sling with a muslin tape to a mesh completely. So, what is your follow-up? Whether these patients have any intimate problem later on in the sexual activity or no?
Yeah.
Usually the patient with I don't use that apogee perigee, so I never use that. Yeah.
No, I
So
am just
this
giving
patient is,
analogy. That was the observation from Dr. Patkar, sir.
yeah.
After laparoscopic mesh, when you follow
Usually,
up these patients, they don't have this problem.
unless there is erosion of mesh, usually this patient they don't have any problem.
Yeah, sorry to interrupt. I think we
The
are.
last question. In
Yeah.
the case which you showed that bladder complication, in that case, I think you will not use the mesh, right?
No,
Or
you can use mesh. You can
after
repair
suturing
the
the bladder,
bladder.
or
Yeah.
better to do a native tissue there.
No. After repair of the bladder, we did
Use the
the
mesh.
Sacrohysteropexy with mesh.
Thank you so much.
Thank you,
What,
Samir.
madam?
Thank you so much.
Very, very insightful discussion. Thank you so much, Padik sir, and also Dr. Samir Pradhan for making it very interactive. But then we have to really stop short. So over to Dr. Santwan to introduce our next chairperson and take forward the proceedings.
Thank you, madam. So our next chairperson is, I would like to have the CV for the next chairperson. Dr. Sudha Tandon, madam, is the next chairperson. She's a gynec endoscopic surgeon and IVF consultant with experience of over 25 years. She's the director of Sudha Tandon Fertility and IVF Gynec Endoscopy Hospital from Chembur and Navi Mumbai. She has been a various
Skip
positions.
this, Santwan. Thank you very much.
Yes, ma'am.
Pleasure to be here. Let
Yes,
me
ma'am.
introduce
So,
the-
ma'am, over to you, ma'am,
Yes.
to introduce our speaker for the session.
Yes. Wonderful to introduce my dear friend.
Now you can skip this also.
She's a great laparoscopic surgeon and a big CV.
We'll skip this.
We'll skip this.
Yes.
She's the first doctor in India to intercede for creation of new vagina. That's nice. And the first doctor to in India to regenerate endometrium in a rare case of endometrial aplasia by using stem cell technology. And I would say that she's very passionate about her work. And there's another big side to her, which is more than academics, which is also very interesting. Over to you. Over to
Padma Shri awardee. The most
Padma Shri awardee.
So I'm sharing it. Thank you, Dr. Sudha. Thank you, Dr. Mala, and Santwan and Yaneshwari and Dr. Kalyan for having me today. I think actually my work became very easy after having a fantastic talk by Dr. Dr. Pandit Palaskar, because I think he covered most of our everything and the indications and everything. Now people listening do know when to do, what to do, and how to do. So I'm sticking to, thank God for having less time now, 20 minutes. I'll be finishing this because 10 minutes are utilized for the discussion. So I'll be sticking to sacrohysteropexy. So we know that we are not here to say whether vaginal method is correct, Sacrocolpopexy is better, or whether we are doing vaginal pexys or the laparoscopic pexys or not. But when we start getting used to one particular technique and our results show a better outcomes, patient satisfaction is good, and everything else falls into place, then we know the next generation comes up learning this technique and it becomes a norm. That is what we are looking at, where we can give a safe surgical technique to the next generation, which is safe for the patient and comfortable for the surgeon. So every technique is correct and good as long we master that particular technique and it is reproducible and with the best outcomes for the patient. And innovation is taking two different things that already exist and putting them together in a new way. So before we actually started sacrohysteropexy, we did have sacrocolpopexy in place, because the failure rates of the vaginal treatments, failure rates of the other sling surgeries led us to do a lot of sacrocolpopexy, which fixes the colpos to the sacral promontory. From there, after doing a lot of kannas, purandres, failure rates, kannas, vircots, and modifications, then we came up with some technique where the uterus can be placed in place with the bony promontory, which is a sacrum. So sacrohysteropexy came up from that, getting both the having sacrocolpopexy in place, then understanding that we need the uterus also for people who need pregnancy. So joining these two techniques, we came up with the sacrohysteropexy. So it's a quest for innovations, which is the need of the day. And today we are talking about all the things which can be done vaginally, abdominally. How can we do in a minimal access surgery? So kudos to the IAGE for taking up this, but pelvic floor disorders. And then we are talking and going forward for it, because half the time of our life we are going to be in menopause. It's no longer 1/3 of our life. It's more than that. We are going to be in menopausal, and then the estrogen deficiency and pelvic floor deficiencies, especially with the vitamin D deficiency, is going to be a norm. So I'm going to take you all again, but what do we know about sacrohysteropexy? The feasibility of the surgery, the technique, the outcomes, the guidelines, and how conclusion. So what do we know? We know that it is uterus preserving surgical procedure for the apical uterine or the vault prolapse. Utilizes the synthetic mesh. So to mesh or to mesh, but something to hold back, we need something to support where the tissues are already weak. If the tissues are already weak, native support is not going to help us. So we need something which is safer, how the technique which can become safer, and with the associated side effects and the complication which can come. So we are utilizing this synthetic mesh to suspend the uterus to the sacral promontory. The objective is definitely restore the uterine support by attaching the uterus to the sacral promontory. So approach can be abdominal, because once it is to the sacral promontory, it has to be either abdominal or laparoscopy or robotic. Minimal access surgery, I don't have to tell this whole conference, whole CME is about minimal access surgery. And POPQ has already been described by Dr. Pandit. So we look at it to first understand where we have to go, where the location of the prolapse is, whether it is the type 1, 2, 3, 4, and then accordingly where we want to get the whole uterus back into the abdomen. So indications are where it is symptomatic uterine decide, that is 2 or higher, with desire to uterine preservation. This is something even at 40 people are willing to have now. So recurrent prolapse with previous post repair, whether it is kannas or whether it is vaginal, whether it is vircots or whether it is prundre, then definitely, or even pectopexy, then this is the technique which we have to go about. Then women desiring fertility, and poor vaginal tissue quality when you look at, and the collagen disorders are there, or hysterectomy is declined by the patient, or contraindicated and there is a descent. And one thing we need to know is no precipitating event like malignancy or a fibroid is there, any uterine pathology which dissuades us from doing it. And we do know the cause of prolapse is something which again Dr. Pandit has clearly told about the obesity, about the asthma, and all the lesions which can lead to it. So when do we not think of this? One, uterine pathology which is coexisting that requires hysterectomy. Second, extensive pelvic adhesions with complete frozen pelvis. This is the time when we cannot be using this technique and we can go for other techniques for nulliparous prolapse. When there are poor surgical candidates, again, GA is not being given, we cannot do this. An active pelvic infection, that once the mesh gets infected, we are going to go into the spine infection, backache, and the necrosis of the spinal segment is something which is known to happen, pushing us to remove the mesh from there. And pregnancy, again, is a contraindication for anything we do with the procedure like this. So preoperative evaluation like I said, detailed pelvic examination POPQ method is what we look at, where the survey, everything is related to the hymen level. And then we look at whether it is above or below the hymen. 0 is no prolapse, to stage 1 to distal process to 1 centimeter within the hymen. Stage 2 is most distal process between 1 centimeter above and centimeter below hymen. 3 is anything below the hymen to 2 centimeters beyond the outlet, and stage 4 is beyond 2 centimeters. So have a detailed pelvic examination taking into consideration all the points of AA, BA, AP, apex, and even the posterior fornix. Then comes imaging, checking where the ureters are, hydroureters are there or not, pelvic ultrasound, where exactly it is, and then MRI if needed. And then the pap smear endometrial evaluation is very important to rule out any malignancy associated. And if associated urinary incontinence is there, urodynamics, SUI surgery can be done the same time, cystocele repair can be done the same time, just like how Dr. Pandit has shown, coexistent surgeries can be done. Then we can counsel the patient regarding the risks, the benefits, and also the alternatives. What are the alternatives we have? Talk to them about the risk and benefit ratio. And then what are the surgical approaches? Like I said, open abdominal sacrohysteropexy, perfect. But since we are talking about laparoscopy, I'm going to show you about laparoscopy and approach. The steps are simple. Patient is in the lithotomy, creation of pneumoperitoneum, dissection of the pre-sacral space, mobilize the uterus, mesh is then fixed between the posterior cervix, that is, or the uterine isthmus, and then to the anterior longitudinal ligament. Then the fixation is either with the tacks or with sutures. Peritonealization over the mesh is important to reduce erosion risk. Mesh considerations, we have been seeing so many meshes, which is good, but what is important is the macroporous is what we look at, lightweight synthetic polypropylene macroporous mesh, because we want the macrophages going into that macroporous, and then the fibrosis develops along that in that plane to plaster it like that. So what we need is macroporous mesh. The position should be either Y-shape or single arm mesh. I'm going to show you both. Fixation is to the anterior longitudinal ligament of the sacrum and the posterior cervix. We need to avoid tension free, secure the mesh with the sutures or tacks, mesh placement and peritoneal coverage is to prevent the erosion. Now, what I want to show is first Sacrocolpopexy, then how we just have to replace that with the Sacrohysteropexy. Originally, I thought I will not show you this. Then when Dr. Pandit said, next speaker is going to talk about Sacrocolpopexy and Hysteropexy, that's when I inserted this video also so that I can show you this. So once we have, this is the vault prolapse. Once we have the vault prolapse, we prepare the mesh then and there into the Y shape. That is a macroporous gynae mesh, which is there from the Johnson & Johnson. So we make it in using the Ethibond suture into Y-shaped mesh, and the length we take is around 10 centimeters, and then we push this mesh inside after once the position is made. First, we take the sacral promontory. This is vasopressin, which is my favorite thing. You give vasopressin and then separate the sacral promontory and make it very clear, and have a look at the anterior longitudinal ligament. Once we see the promontory and the anterior longitudinal ligament, I'll go a little fast because this is literally a 11-minute video which I'll not waste. So that is the 1 minute. I'll go back to show the promontory ones. Yep. This is the promontory once we have separated, and with the vasopressin and everything is separated. There we get the, and you can see the sacral vessel there, longitudinal ligament and the vessel there. Ureter very clear, taking out all these adhesions which are there near the vault and the omentum. And once that is done, and through the small vaginal obturator, we push the vault inside. And we need to be very careful about the bladder incision and the anterior part of adhesions which are there when it comes to vault. So pre-sacral region is now being separated and away from the posterior vaginal wall. So once we separate the pre-sacral region and then go anteriorly, this is still the pre-sacral region. Let me go a little faster. And then go anterior and separate the bladder. And the plane, like we said, always is the most important thing. Either we are going with a scissor or we go with harmonic. And I would actually most of the time go in the right plane and use scissor to push the bladder down, because in the postmenopausal woman, the tissues are very thin and the higher chances of lateral thermal damage is going to be there. So now first suturing is always done in the posterior because automatically mesh falls anteriorly once we start suturing it. So 3 layers of either using ethibond, or I usually prefer ethibond, but otherwise Vicryl also can be used. But I usually believe in the long delayed absorbable sutures is what we look at. So we are taking a posterior sutures here and 3 to 4, and then comes the anterior suturing. And the question was whether how long do we go? I go a little above the bladder neck, because I really do not want it to go till the bladder sulcus. So we do it around 2 centimeter onto the anterior vaginal wall, in between the bladder and the anterior vaginal wall, not till the level of the urethral neck. So we are taking 3 sutures here, and that's there. And once that is done, we just have to pull it above till the promontory, and at the point where we see the longitudinal vessel, there is the point where we tack it onto the periperiosteum. So we do around 2 to 3 tacks there. And once the tacking is done, or we can use suturing. In the next technique, I'm going to show Dr. Mala's video where she'll be using suture. So once we do this tacking, I usually do 2 to 3 tacks there, and then the whole of the mesh, extra mesh is then trimmed away. We cut it away, and then the whole mesh is now interiorized by covering it up with the V-lock sutures. Again, that is a delayed absorbable sutures. So once they are completely interiorized by cover, peritonealizing the whole of the mesh, and irrigation and everything is done, and final look is going to be like this. The whole mesh is completely covered with peritonization, and when we see at the last, the whole vault goes up. So using V-lock suture is something which we take into, I hope is there a last view in this. And we cut it up, the extra mesh is taken off, and everything is taken. You can see there is no mesh which is exteriorized. And at the end of it, I always believe in putting a Sacrohysteropexy or an interseat so that they do not have any other thing. So this is the simple case of sacrocolpo. So when we utilize it, the same thing. Now, Sacrohysteropexy, this is a video by Dr. Mala. So I was not having this video, so I asked the help of my friend, and she helped me giving her Sacrohysteropexy. Thank you, Mala, for doing this. Oh, why did the video go off? Okay, so this is sacral promontory. Here, she's separating the sacral promontory. And here the ureter, you can see very clearly the anatomy of the ureter. So at every time when we do anything to the sacrohysteropexy or sacrocolpopexy, we have to delineate the ureter and see that where we are before we open the peritoneal window lateral to the medial to the ureter. So sacral promontory, and then the ureter is identified here. The anterior longitudinal ligament is identified here, and that is the uterosacral. So once we know the anatomy well, that's where comes the anchoring of the posterior part of the cervix or the isthmus. So there is something which is going wrong. I hope this plays now. Why Mala's video is not thinking of playing, I don't know. But anyway, then the whole bowel loop is now being anchored, taken away from the plane of where we are doing the dissection by pulling it above into the anterior abdominal wall. So you can see here the paracolic gutter, which is very clearly delineated here by separating this. And then now the lateral peritoneal dissection is being done. Yeah, she's getting it away. I'll go. Yeah. The whole dissection between the paracolic gutter is being opened along this whole length. Hello. I hope this works. Yes. So you can see the beautiful planes through which the whole length is being opened in between the colon and in the lateral pelvic wall, medial to the ureter. You can see the peristalsis of ureter, which is going here. So till the lower margin, that is the cervical area. So I'll go a little faster here. So And once this is exteriorized and the lower part of the cervix is being separated by the pre-sacral area, and once the pre-sacral area is being pre-rectal area is being separated, we get to see the posterior part of the cervix there. We are going lower enough to get the posterior part of the cervix there. There, the mesh is being placed and the length is being adequately taken, around 10 centimeters is what we usually take, and then take away the rest of the things so that it will not be under tension. Now, the posterior part of the cervix is now being anchored to the mesh which is placed here. It is not the Y shape. It is only the single which is posterior to the posterior part of the cervix and not to the anterior and posterior. You can also do a window technique through which anterior and posterior can be done using a Y-shaped mesh. Then also we should be very clear that we should be closing every part of the mesh which is will be exposed. So here Ethibond is only being utilized again, and the suturing is being done. So 3 to 4 sutures are being done with the posterior part of the cervix. There. The third suture, anchor suture. So once that is done, simultaneously, the closure of the peritoneum is being done so that none of the mesh gets exposed. We can either close it at the end, or we can close it simultaneously, closing it and coming above till we see that it can be closed properly. So the mesh is being pulled and sutures are being taken on the anterior longitudinal ligament onto the promontory. So you have seen the tracker and you have seen the sutures being put. So every surgeon to their own how they want to do it. But both are right. Tracker has its own advantages of ease. Suture has its own advantages of not going into the periosteum too deep, so that you can get away with the pain which is lesser. This is delayed absorbable. So once the sutures are, at least 2 to 3 sutures are being put, we're using the Ethibond sutures at the anterior longitudinal ligament. Once those 2 sutures are put, then the peritoneal closure, which we have started from below, is now taken away up to the promontory, so that the whole layer of the peritoneum is completely closing the mesh which is on the top of it. So this is the way the whole uterus comes above, and the sacrohysteropexy is being performed. Then the release of this anchoring bowel loops is done. So intraoperative tips would be basically to avoid the middle sacral artery injury and to avoid the over-tightening of the mesh, use of nerve sparing technique, adequate peritonization to reduce the adhesion. These are the things which we have to understand. Peritonization is the better way to go. Post-operative care is analgesia like we do, but early ambulation, Foley's for 24 hours is something which is not mandatory, but usually we are used to doing it, because along with it there will be a cystocele repair. When cystocele repair is done, it is 24 hours we put it. And VTE prophylaxis, avoid intercourse and heavy lifting for 6 to 8 weeks. Pelvic floor physiotherapy, follow up 1 week, 2 weeks, 6 weeks, and 12 weeks is what we look at. The advantages, like we know, uterus is preserved, so anatomical and functional restoration, low recurrence compared to native tissue repair, and minimally invasive options are there. But we have to understand general surgical risks of bleeding, infection. If you do not...
Sorry to interrupt, ma'am. Another 2 minutes more.
Yes, I'm finishing. Ureteric injury, mesh complications of erosion, dyspareunia, constipation, pain, long-term prolapse recurrence is there. Outcomes is what we have to look at, that high anatomical success rate, improved quality of life, uterine preservation benefits, and preservation of sexual function is there. And short-term outcomes, like I said, the outcome success rate is 98.6. Long-term, there are incidents of recurrences which have been told. Comparative outcomes will be no RCTs, no significant differences between other techniques, and versus the uterosacral also no significant difference. So this is the way it is compared with the other techniques, but it is sacrohysteropexy, the recovery is faster and recurrence rate is low. So with pregnancy, there are reports of pregnancy with this, but cesarean is the way to go. Special consideration is definitely when women are desiring pregnancy, concomitant procedures we can do an impact on sexual thing. So to conclude, the efficacy is 85 to 100 depending on who's doing it. Safety, again, mesh issues are the thing which we have to look at. It is fertility preserving. quality of life as impact and consideration is, yes, there is a post-op constipation, mesh selection and surgical expertise is vital. Recommendation is we have to look at ideal candidate and do a pre-op assessment and technical optimization, and evidence gaps are there. There are guidelines which are there, and to summarize, it is minimally invasive and appropriate case selection is a skill, and mesh safety and skill is essential to success. Thank you. And I would like to say there's a single light of science, and to shine it anywhere is to shine it everywhere. Thank you.
Thank you, ma'am. That was a crystal clear presentation. No doubts for anybody. Thank you, ma'am. Sudha, ma'am, over to you to start the discussion.
Yeah, thank you very much, Manjula. I think really very crisp, very clear. It looked a very simple surgery, but I really do not know whether it is. I would like to know what are the difficulties that one can encounter in drop, and secondly, as compared to the anterior prolapse repair, which is the cervicopexy, so which one would you normally want to do or you would prefer? How do you decide between the two? I would put it that way.
See, I usually do posterior cervicopexy only. Anterior, the recurrence rates are very, very high because of the leading point is there. So in the posterior, it can be a cannas, it can be a modified Virchow, which I really modify it in such a way that I go from anterior posterior and then take it out through the lateral broad ligament and put it to anterior the sling, the anterior superior iliac spine. But again, posterior has the least incidence of recurrence, and even the sexual satisfactions and all mesh erosion rates are also very, very low. But intraoperatively, yes, in posterior, when we are trying to do anything, the bubble loops, if you are not going to take it out of the field properly, or sometimes you do have a lot of fat over there when the patient is very obese, you see retroperitoneal fat which is quite high, and ureter comes in the way. So we have to always look at where is the ureter. The opening where we are doing is between the ureter and the bubble loop. So I started using a lot of vasopressin into that whole layer, so it automatically opens up and the clear way it comes in. But it depends on individual person. So I use vasopressin a lot.
Okay, that's a very good practical tip that you have shared. Yeah. Yeah. And what about the rectal problems associated with this?
Yes.
And how tight you would like to, make it so that it does not.
It is never too tight. It is tight enough and not too tight. So it's individualized. I might think it is not tight, but the more tighter you go, it is going to cause the constipation which is going and back pain which is going to be there. So we just pull it around. Like I said, we take around 10 centimeters of the whole mesh, but we put around 8 or 7 depending on the length of the sacrum to the vault which we look at. And the rest of it we trim it and take it away. And now when we put it, the commonest side effect we see is the constipation. So we tell the patient beforehand only that yes, some amount of constipation is going to be there and you might have to use Dufelac later on. So we never had till now any mesh erosions or anything in these particular cases, because mesh erosion, where does it erode? Into the abdominal cavity, and then the bubble loop should get adherent. It is never into vagina, which is used for sexual intercourse. So mesh erosion chances would be very less if we have a good peritonization and we do not see it. So I feel that posterior and good peritonization and taking a macroporous mesh is the way to go for.
Thank you. Thank you very much. I think there would be, are there any questions from the audience, Mala?
So I think, yeah, no questions, madam.
Yeah.
And thank you, Mala, for the video. Fantastic video.
Thank you. Thanks to you.
Thank you, Mala, for the invitation. Thank you. And thank you again, Manjula. Lovely.
Thank you, Dr.
It was a very, very good presentation.
As much
Sure. Thank you so much for being a part of it. Yeah. Over to Dr. Santwan or Nyaneshwari to introduce our next chairperson, please.
That was two well accomplished women there for you. So please let us go on to the next speaker of the day. The next speaker of the day is Dr. Sushila Saini, and Dr. Sita Lakshmi ma'am is going to be chairing the session. Dr. Sita Lakshmi ma'am is currently working as a HOD in the Department of Urogynec, Suvita Medical College and Hospital. She's a former Dean of Government Medical College, Virudhunagar, a certified urogynecologist with special interest in POP, especially wall prolapse and urinary incontinence. She's a fellow in urogynecology. She's been awarded a PhD in urogynecology, has 15 national and 15 national and international publications, a faculty in various national and international conferences, a customary orator in women's health in All India Radio Chennai, has given interview in various TV channels regarding the same. Over to you, ma'am. Dr. Sushila.
Good evening, ma'am.
Dr. Sushila.
Yeah, Dr. Sita Lakshmi madam can introduce Dr. Sushila Saini. Sita Lakshmi madam.
Yes. Am I audible?
Yeah.
Yes, ma'am, you are audible, ma'am.
Thank you for the introduction. I invite Dr. Sushila to talk on laparoscopic pectopexy. She is the director, Jaipur Durbin Hospital. She is the president, Association of Gynec Endoscopic Surgeon of Rajasthan, vice president, Rajasthan chapter, North Zone coordinator, Foxy Endoscopic Committee 2018 to 21, managing committee member, IAGE, ex-assistant professor, JLN Medical College, Ajmer, awarded Young Achiever Award in West Zone, Your Foxy, and she won the Foxyian Award in November 2019, coming up with own endoscopy manual for learning of young building endoscopist. I welcome Dr. Sushila for her talk.
Thank you, Sita Lakshmi ma'am, for kind introduction. I would like to extend my thanks to Dr. Malaraj and IAG, Dr. Kalyan, Dr. Pandit Palaskar sir, Dr. Sujal Munshi sir for inviting me here for this talk. And this is a Urogynec dedicated webinar, and Sacrohysteropexy is already covered. And I am going to cover the Pectopexy, the alternative technique. Whenever we can do, as we all know, that Sacrohysteropexy is the gold standard technique, and we all started with the Sacrohysteropexy only. And whenever in the time when we are doing a lot of Sacrohysteropexy, patient coming with a lot of the complaints like backache, like Manjula ma'am right now shared with us that patients definitely having the constipations.
Yes? Any problem in sharing the screen?
No, I think some internet connection, no? It's frozen.
So Sushila, we are unable to see, hear you.
Dr. Sushila, I think she's her internet. I'll just call her.
I think the internet is probably gone. Someone is calling?
Yeah, I'm calling her.
Yes.
Hello.
Yes, to connect.
हाँ डिस्कनेक्ट कनेक्ट हो गया इंटरनेट प्रॉब्लम है ये क्या you have to log in again
Till the time we can continue on the topic.
Yeah.
Yes. So probably the first group of surgeons they started this Pectopexy was from Pune group only, and the first wing was open surgery. Dr. Bhavesh Joshi was one who first published it. They had a 10-year study of 103 cases, and they also had a very small laparoscopic wing by Dr. Mahendra, own friend. 3 or 4 cases, and somehow it was taken over by Germans, and Dr. Gontur Neuer has the highest probable series. Dr. Samir will be able to tell us, but I think they have now more than 1,000 cases of Pectopexy. So this particular surgical technique got popularity last 1 decade, and we were all discussing in previous this thing. The Sacrohysteropexy has remained gold standard for past 3 decades, but Pectopexy has some advantages. I think our speaker will speak on it once the connection is there. But advantages, what literature says is it is relatively less uh, compared to this on the vital organs. The promontory, if you look at the bifurcation of aorta, middle sacral vessels, the hypogastric nerve, all these vital structures are there, and the dissection really requires skill, especially in obese patients, patients with previous bowel surgeries. These are the patients which are sometimes though ideal candidate for sacral promontory, the access is difficult. So in such cases, pectineal ligament is a good option. And for pectineal ligament, Dr. Pandit very rightly showed that whenever there is associated lateral cystocele, you need to dissect in the same space. When patient has associated SUI, you need to dissect in the same space and reach till Cooper's ligament, and you can do additional procedures. So now we are getting repeated patients of failed vaginal surgeries. Dr. Samir Bhai was telling that native tissue was done. And then as an alternative also, it is a good technique. Samir Bhai, your insights on this?
Yeah, I think you said Dr. Bhavesh Joshi, it's Dr. Vivek Joshi.
Vivek Joshi. Sorry. Yes. Thanks for correcting. Yes,
Yeah.
Dr. Vivek Joshi.
So he's a very excellent open surgeon, and he is the first person who decided to do this use of Cooper's ligament. And
yes,
what I want to know is the main concern which he said was in I think Sushila madam is back.
Yes, Sushila madam, are you ready with your presentation? Yes.
Dr. Sushila, you are muted.
Yeah. Yes, my internet connection was somehow lost, so I have to just change the place. So another, I connected with another Wi-Fi system. So just I'm sharing again my PPT. Sorry for this inconvenience.
Please go ahead.
So we are here with the indications of the Pectopexy. So always we have to some other armamentarium in our portfolio that we can actually apply when there is some problem, when we cannot use the standard technique like Sacrohysteropexy. So Pectopexy was introduced in 2007 by Banerjee and New, and it is an alternative prolapse surgery technique where we place our mesh in the anterior compartment, and mesh is of this size and it is placed like this way. So I'm going to show the video how actually we are performing the Pectopexy. So this is a case of third degree uterovaginal prolapse, and you can see there is not much cystocele or much rectocele, only the central apical prolapse only. So as a first step, we have to introduce the uterine manipulator to push the uterus inside, and there should be the straight push, and then lift the UV fold, and then just separate the bladder. And we have to lift completely the bladder body to separate it and dissection it in the proper plane. Whenever we are placing the mesh, it should be placed properly, because if you damage the fascia, this fascia should be with the vagina and one fascia should be with the bladder. If we are going inside these fascias, there is always a chances of the mesh erosion. So this UV fold cut have to extend it till the lateral pelvic wall, and this is the round ligament, and just anterior to the round ligament, and this is the medial umbilical ligament. We are just cutting between the lateral to the medial umbilical ligament. This is the medial umbilical ligament, which actually represent the obliterated umbilical artery or continuation of the internal iliac artery. Now we are just pulling this ligament medially, and we are dissecting between this ligament and lateral pelvic wall. And lateral pelvic wall, you just find this external iliac vein. And just below this external iliac vein, you will find a hard structure and whitish structure. This is the pectineal ligament. And just below this pectineal ligament, you will find the obturator nerve here. So we have to little bit careful. This is the obturator nerve, and we should not damage it. And this is the obliterated umbilical ligament. You can just check it. So this is the exploration of the pectineal ligament. Now same steps we are just duplicating on the other side. Now we are again extending our incision parallel to the round ligament till the lateral pelvic wall. This is like we are extending the incision, we are just pulling over the round ligament and anterior to the round ligament. Now identifying this medial umbilical ligament. Lateral to this medial umbilical ligament, this is extrailiac vein, and just below the vein, this is the ligament. And below just this ligament, there is a obturator nerve, and anteriorly there may be the more. This is venous connection between the external iliac vein and the internal eyelid vein, which is known as the corona mortis. We are just pushing the bladder more down, and this is the preparation of the mesh. We are preparing the mesh from the 15 by 15 size mesh, and this is the 1.5 centimeter broad from the edges here, and this is around 3-4 centimeter length in the center. This center part keep long to prevent the cystocele or to treat the cystocele. Now we are just placing it flatly over the anterior compartment, over the cervix, over the broad ligament, and ends are going till the both side of the pectineal ligaments. Now we are using the 2-0 ethibond suture. This ethibond suture, we are just fixing this mesh, and this ethibond suture is the permanent suture. It is a braided suture. It is handling is easier like the Vicryl. Now we are fixing the ends with the pectineal ligament. So we have just passed our needle through the mesh. Then we are taking this full bite or full thickness suture through this pectineal ligament. And here should be the needle just rotating over, sliding or gliding over the bone. And this is the 2 number thread here. For fixing at the cervix, we are using 2-0 ethibond. Here we are using the 2 number thread. And now we are again passing this needle through the mesh. We are not just tucking one suture and like tying the knot, because if you are not taking this like this mesh, then there may be the avulsion or the mesh may be cut through the edges. So we always place like this. And first 3 throws we have to place, like you can see, we have placed the 3 throws here. It is actually for the non-tightening, non-loosening up of the first knot. So this knot should be placed surgically or the flatly, and you have to tighten it properly. Then 2 throws and then 1 throw. So this way 2 suture we have taken on the left side. Now again we are taking the suture on the right side. So again we are taking the full thickness suture through the anterior longitudinal ligament, and then we are just passing this needle through the edges of the round this mesh. And again here also we are taking the 2 sutures. Many people taking only one suture on the both the sides, but we always prefer to take the 2 sutures, because one suture may cut up, one suture may loosen up, the mesh may be cut through, or anything can happen. So at least there should be the 2 sutures to hang this mesh with the bone. This way, one suture we have placed and another suture. Initially, if you are not comfortable with the suturing, you can place the tackers. That is a titanium tackers, metal tackers you can easily place. For placing the right side tackers, you have to put the tackers from the left side port, and from the left side, you have to place the tackers from the right side port. And it should be perpendicular to the bone, and many a time it may slip off, so you should just support the tacker like this way with the artery forceps. So now you can see the uterus gone inside. It was the +3 +4 before surgery. Now it is -3 -4 inside the vagina. There is whenever we are placing the mesh in the anterior compartment, the posterior compartment may be widened, and there may be the enterocele and high rectocele. So for prevention and treatment, we always place a Mascovitch suture in the posterior compartment. So this is the uterosacral ligament, and we are just pulling it and giving a cut. If we are just thinking that ureter may not be pulled up with this suture, because whenever you are doing the uterosacral plication or we are placing the sutures over the uterosacral, ureter may be nearby, and here is the ureter. So we are just giving little incision between the peritoneum lateral to the uterosacral ligament, and then we are just closing this POD. This is the ureter here. So this is again we are using the ethibond. This is again 2-0 number, not 2 number, because 2 number is quite thick and needle is quite thick. So this much big needle we cannot put with the peritoneum. And we are started with the uterosacral ligament on the right side, then taking the suture through the peritoneum lateral pelvic wall. and then taking the suture through the serosa of the rectum. So this is the standard way to place the Mascovitch suture and obliteration of the POD and treatment and prevention of the enterocele. And this actually gives the little protection in the posterior compartment, because whenever we are putting the mesh in the anterior compartment, it lifts up the cervix and posterior compartment widened. This is the same way like we are putting the mesh in the posterior compartment. It pulls the uterus or cervix posteriorly and urethrovaginal angle changes and de novo SUI creates. So in the sacropexy, there is up to 40% chances of the de novo SUI. It may be less, it may be 0, it may be 4%, maybe 5%, but up to the 40% reported. But with the pectopexy, there is no de novo SUI because we are not changing any angle of the urethrovaginal angle. And prevention, enterocele may be there, so which we are already placing the suture to prevent and treat. And if there is a low rectocele, then low rectocele can be treated vaginally. So this way, this is a bursting suture which is going through the lateral pelvic wall from both the side, both the uterosacral included. Posterior surface of the cervix is taken and anterior surface of the rectal serosa included. So this way, complete bursting completed. Now 3 throws again taken, and now we are just tightening this suture. So whenever we are just placing the suture, we need to little bit loosen up the uterus, and we are just fixing the knot so it may not loosen up because it is under pressure. So uterus again tilted posteriorly, and then 2 throws, and then lastly 1 throws. So this way, this ethibond knots are fixed, and this is the standard pattern which we are following for each and every ethibond knot, 3, 2, and 1. And this way, posteriorly suture is placed. So this is the mesh is placed anterior in the anterior compartment, and proper peritonization is must whenever you are placing the mesh. This is the standard way. We are closing this peritoneum with the vicryl. This is the number 1 vicryl. You can use 0 number, you can use 20 or the 1 number vicryl. This doesn't matter. And this is the continuous sutures, and proper patronization of the mesh is necessary. Mesh should not be exposed. As already Dr. Manjula said us that mesh, if mesh is exposed, then intestine may be stuck up here and there may be the erosion into the intestine. And mesh placement should be always flatly. It should not be pulled up. It should not be enough tightened, and it should not be like a straight bond. Like it is not. Should be the flexible hammock. So this actually act as a hammock, and uterus lifted up and placed at the normal level. And this pectineal level ligament is as the S2 level. So this is the final picture which you are seeing. That uterus is lifted up, but little bit retroversion is there because we are lifting it at the midpoint or the ischemic point of the uterus. So fundus part is little down. So we have taken 1 or 2 suture of the vicryl into the round ligament, so making it little antivert. But it is a good technique. If you cannot place the you cannot do the sacropexy in any case, or sacropexy is failed, then definitely you can use the pectopexy. This technique can be used for the vault prolapse also. And I think in the vault prolapse is easily placed. There is a little sigmoid adhesions after the surgery, because vault prolapse is always after the hysterectomy. So just identifying where it is the joint of the vagina where we have placed the sutures initially, and then anterior is the bladder. Lift the bladder completely and then just separate it sharply. Identifying the vaginal wall is mandatory, and you should not go into the vaginal wall. If you go into the vaginal wall, then definitely there is erosion into the vagina. And if you go more nearer to the bladder, then there may be the chances of the erosion of the mesh into the bladder. So this way, we are completely dissecting of the bladder down, and this is the anterior compartment dissection, and or this is the posterior compartment dissection. So posteriorly, we are just separating the peritoneum to make a room to place the posterior end of the mesh. And if you want to correct high enterocele, then you have to dissect little more, and rectum has to be dissected posteriorly. Like this is the rectum here, and we are just dissecting between the rectum and the posterior vaginal wall. So this is the rectum here. And now again, this is the round ligament part. And this is the extrailiac artery, which is pulsating. So we have to dissect here, just below the extrailiac vein. So dissection is the same, but there is little landmark loss in the wall prolapse case. So there is 2-3 challenges, dissection of the bladder and the wall prolapse case, because already the bladder is already dissected in the case of hysterectomy. So again, we have to dissect it from the vagina. And then we have to locate the pectineal ligament in this case, and the placement is the same. This is the extrailiac vein. Just below the extrailiac vein, we have to dissect, and we have to cut this fat and expose this peritoneal ligament properly. If you not expose this pectineal ligament properly, and you put the sutures only to the fat tissue, then there will be definitely failure. Because many a time we are not able to dissect, there may be the bleeding. We are not oriented to the tissue identification, and we are just separating the peritoneum and taking the sutures through the peritoneum. So that is also making the cause of the failure. Because if the mesh is not properly attached, suture cut through, so always all makes the chances of the failure. On the both the side, you have to do the same thing like this way. Here you can see the beautiful pectineal ligament here. And the design of the mesh in this wall prolapse case is little different. It is a cruciate shape, like anterior arm and posterior arm and both the lateral arms. So this way we are placing the one suture at the center. So fix the mesh so that it will not displace and it is remain at the place. So this is again, we are using the 2-0 thread, and then anterior arm is again fixed on the anterior vaginal wall, posterior arm fixed on the posterior vaginal wall. How much time I have, Dr. Mala?
Dr. Mala?
Ma'am, you still have around 6 minutes.
Okay,
Yeah.
thank you.
10 minutes, yeah.
Okay. So we are just placing 3-4 sutures anteriorly and posteriorly and fixing the mesh ends again at the pectineal ligament. So this way, actually we have not to expose the sacral promontory. We should not have to dissect between the rectum and the paramedial space where actually the inferior hypogastric nerve is there. In the Pectopexy, we have not to dissect anything. We just prepare the vault, dissecting laterally on the pelvic walls and placing the sutures. So this is quite comfortable for the old age patients. Here we have to not give any head low position, very low, like little bit head low position suffice for the Pectopexy case. And in the wall prolapse cases, if you fix the mesh like this, then definitely it will go nowhere and vault will be placed in the normal place. So this way, again, we are taking the 2 sutures, both the sides, and peritoneum is closed as usual with the vicryl. So you can see the final picture after closing of the vicryl, the vault level is at the around S3, S4 level. This is the level and this is the level. So vault is placed properly and we have not to expose anything around the rectum or the nerves. So this is the cruciate shape mesh which we are using for the wall prolapse, and it is a quite good technique and patient is quite happy because there is very less side effects after the surgery. So Pectopexy can be chosen for the patient who is obese, because in the obese patient there is difficulty in doing the sacropexy. We cannot give the much head low and there is a lot of fat, and in the posterior compartment dissection is always difficult than the anterior compartment. So with the difficult promontory dissections like the fatty presacral area, bony deformities as there, dense bowel adhesions as the promontory, Presence of the unexpected vessel variations or less flexible thick sigmoid colon may be there. Previously failed sacropexis, wall prolapse cases, and associated anterior compartment defect with the apical descent, we can choose the pectopexy. This is a paper which is published in the JMIC for pectopexy. And this is another paper which is published by the Sir Nu, and they have compared the 43 pectopexis with the 40 sacropexis, and they mentioned that the significant average operating time is less and everything is good with the pectopexy, and they suggested the new method can be considered in patients where the pre-sacral preparations bears the higher risk. Again, there are another paper supports with the Dr. Nu, who is invented the pectopexy, and this shows that there is a 0% defecation disorder. That is a very good thing with the pectopexy, that constipation is not there, backache is not there, and de novo SUI is not there, and pain very much less, and operating time is significantly less with the pectopexy. And modified laparoscopic pectopexy is also there. Little bit every person makes a little changes, and then it is also that gives the good result. This is our experience which we are doing, and we are performing the pectopexy in 2017, and this data is since 2024 July, and till then we have operated 268 cases, and out of that 5 cases has the recurrence, and the 2 cases is the first degree cystocele and first degree rectocele, and apical descent is also there, and de novo defecation disorder is not there, and de novo SUI is not there. So apical prolapse success rate is 98%, and cystocele and for rectocele is the 98, 99. Rectocele we always repair vaginally only with the PFR technique. So laparoscopic sacrocolpopexy is the gold standard till date, but if we cannot perform or it fails, then we have to choose the another option. So drawbacks of the sacropexy, we know the defecation disorder, constipation, SUI, backache, dyspareunia, GI disorders, rectal injury may be there, bowel obstructions may be there, mesh erosion in the rectum may be there, and obstructive defecation there, infective lumbar lordosis may be there, hypogastric nerve plexus injuries may be there, and osteomyelitis of the sacral promontory may be there. And if we are placing the mesh between the sacrum and the vagina, there is always narrowing of the pelvis, and this causes the defecation disorder because of the reduced space in the pelvis. So laparoscopy pectopexy can be chosen and good alternative of the sacropexy. It is equally effective and shows the no defecation disorder, backache, and neuralgia in the long-term follow-up. And if you place the mesh properly, so there is less chances of the mesh erosion into the anterior compartment like the vagina or in the bladder. So thank you so much for patience hearing, and if there is any question, I am happy to answer.
Yeah.
Thank you, Dr. Sushila, for your excellent presentation. Still, I advise Moskowitz procedure when pectopexy is done, because the obliteration of pouch of Douglas is very important, not only to prevent the future enterocele, also to correct the enterocele. And so the pouch of Douglas obliteration is very important when you do a pectopexy. I appreciate that. And it does not have a long steeping learning curve for pectopexy,
Yes.
because sacrocolpopexy has a deep learning curve, whereas pectopexy, it is not steep learning curve, so it can be done in cases where sacrocolpopexy is not much applicable. So I thank you for your excellent presentation, and it is a new technique and it has to be adopted. And how long you have the follow-up for this pectopexy, Dr. Sushila?
Like
Maximum
we are
follow-up.
maximum follow-up like 5 years.
5 years. Okay.
Yes.
That is a very good follow-up. Okay. Thank
Yeah.
you. Thank you.
Thank you, ma'am.
Thank you so much. Thank you so much, Sita Lakshmi Madam and Dr. Sushila. It was an excellent presentation. So basically, pectopexy is really coming up because it does not compromise on the pelvic capacity, as it was well pointed out. There is no injury to the hypogastric nerve, no injury to the ureter. So de novo urinary incontinence and also the fecal incontinence, all those advantages are there. And also there is no sexual dysfunction also because of the non-involvement of the hypogastric nerve. So these are the basic advantages. Of course, sacrocolpopexy also is wonderful procedure, but only thing is because of it's going into the pelvic cavity, you have to be little more clear with your techniques. And another, now recently what they have found is like a pectineal ligament is lot more thicker than that of the anterior longitudinal ligament.
Right.
But they
thickest,
have
thickest and the strongest ligament of the body.
They have dissected in the cadavers and also found that it is much thicker, almost 4 millimeters. That is, when they put the tacker onto the anterior longitudinal ligament, there is a problem with osteitis. So that is because the ligament is thin, but the same tacker, when put in the pectineal ligament, it does not cause the same problem. That is because of the thickness of the ligament. That is why pectineal ligament are supposed to be much better. And also they say that it does not change the axis of the vagina also. It is at the S2 level. That is another major advantage with our Pectopexy. Sita Lakshmi Naganam has very beautifully highlighted like why we have to definitely do a mandatory to do a Moskowitz. So, and you have demonstrated very nicely. That was a very excellent video on that. So thank you so much. With this, I think we also have to wind up. So I would like to thank all our speakers who have taken all the effort to prepare for this webinar and share their thoughts. And it was made very interactive with our chairpersons and also our coordinators who did an excellent job. I would like to thank our secretary, honorary secretary, Dr. Sujal Munshi, to give away the vote of thanks, please.
Thank you. I would first like to congratulate our leader, Dr. Kalyan Barmde, for initiating this very good webinar series. All efforts are taken by none other than Dr. Mala Raj and Dr. Santun Mehta, and beautifully they have been doing it with all their great efforts. Yes, so today's session was on pelvic floor disorder, and we had some wonderful discussion on this. I'm especially thankful to all the speakers and the session experts, and to all the delegates. I'm sure they must have been learning from this. If you have any questions, all the speakers are accessible, and you can put it on the wall. Wish you good learning. Thank you.
Yeah. So thank you so much. I would also like to thank Shield Pharma for their excellent academic support. They've been really kind enough to sponsor all the webinars for us. Thank you so much, IAG, for this initiative.
Thank you. Thank you.
So we'll meet again next month on the first Friday of every month. So this first Friday we were held up with something, so it came to second. So next month we'll meet the first Friday. Thanks a lot.
Thank you, Mala ma'am, for the opportunity given. It was a wonderful session. Thank you.
Thank you, Santwan and Dr. Jnaneshwari. Thank you, Sudha madam.